we'll start with some things about debriefing. We have a couple different talks on debriefing and what it's like. Several of you have done simulations. How many of you do an organized debriefing after or in the midst of scenarios? Does anybody already do that? So none of hardly any. So this is going to be one of the spots where a lot of the learning is going to occur. This is where this is going to be the hardest part for you, because this is where you're more engaged. You're trying to draw things out of people, and this is going to tax your skills a little bit. But having gone through a lot of scenarios by the time the trucks come and you're working on the trucks, and seeing debriefing, being debriefed, and being the debriefer before that all happens, you'll have a pretty good handle of how it works. And we can teach you as much as we want, we can show you as much as we want, but until you've actually been in the process and actually been a debriefer or been debriefed and had the hard questions asked of you, only then can you really become somebody that's fairly good at debriefing. And I will never claim to be an expert at debriefing, because this is kind of like an art that it seems like you're continually trying to learn a little bit more about. So our objectives. Why is the debriefing necessary? What makes it important for us to do this? Why is there learning going to occur there? The goals of debriefing, the different elements, and what's the process, how you carry out the debriefing. The methods, because there's different types of debriefing, different methods that you can use, and the one you pull out of your bag will be the one that fits the scenario that you're using. And then you need to be able to recognize the good and the bad debriefing behaviors, as well as the learners' types of behaviors as well. So historically, what is debriefing? Merriam-Webster, way back when, to interrogate after a mission in order to obtain useful information. That sounds like a good debriefing, kind of like the military does after they have a military campaign or they go out into battle. They'll debrief afterwards. After the jets fly a mission, they have a debriefing afterwards. They also use it to strategize so they can have future missions. One of the things that we do at the medical school, we have what we call an OME, or Office of Medical Education, retreat every June. And that's when all of us sit down that have anything to do with the curriculum for all 4 years. And there's 20, 30 people. We all get together and we virtually tear apart the curriculum and try to rebuild it, but only after we debrief, because there's some people that are in this part of the curriculum, some are here, some are here. This group doesn't really know what this group does. So when they say we want to add this to the curriculum and they say no, they need to understand. So we go through a debriefing process of the whole curriculum before we start tearing it apart and putting it together. Psychological damage. Can you imagine the stress that happens after, for example, a city has a major disaster, people die, and it totally turns the town on the ear. A flood, for example, that's happened in Fargo and Minot and in Grand Forks in the past. You know, even if you weren't involved in debriefing, medical professionals often debrief. The National Guard will debrief. The city founding fathers or whoever, the people there that run the city will have a debriefing, because they need to go over things to make sure that they can improve, so when this happens next time they can do a better job. Sometimes it's just a one-time conversation that's somewhat structured to help out in a stressful event. That's not quite the way we use it, because ours are one time for that simulation, but we'll get the people back for more of them. To mitigate stress, one of the things that we don't do here at the medical school, unless we tell the students beforehand, we're not going to let a simulator die on a first-year student. We've never had a problem, but there are reports in the literature of post-traumatic stress syndrome in medical students who had a simulator die on them. So that even just goes to tell you how real these situations can be. And critical incident stress debriefing, if you've been involved in the military, if you've been involved in disaster plans or mass casualty plans, you'll know something about that too. And then after a traumatic event, whether it's an individual or, like I mentioned, that whole citywide thing, there's debriefing. So that's more of a historical side of thing. And then there's this experimental psychology type of debriefing. Sometimes they put participants in a role where they are deliberately deceived and they're carried through the scenario. This isn't medical scenario, but they put them into a situation and they deliberately deceive them to see what their actions are going to be. And then they have to debrief them afterwards, because if they just say, you know, this wasn't really this wasn't real, you know, this is all a hoax, that's a major issue. And I can't remember if it's Leo Tolstoy. I think it was Leo Tolstoy who was imprisoned for 8 months, and they were never planning to execute him, but when back in Russia in his day in the early 1900s or late 1800s it was, he was put, I think it was him, he was put in prison for 8 months, in full prison, treated like prisoners and everything, and they came to execution day, and they took him out to the execution squad, blindfolded him along with a bunch of others, and then had planned, a guy rides in on a horse and tells the executioner, nope, call it off, and then they let him go. And they staged that. They never planned to execute him, but they staged it to prove a point to them. They wanted to scare the bejeebers out of him for some reason. But here he was standing there with the blindfold. Before they put the blindfold on, there's the executioner standing there with their guns or whatever. He knew he was going to die. Can you imagine the stress that that might have? So there's going to be a lot of debriefing. That's the psychology side of things. And then how about the crew, the people that searched for that balloon boy in Colorado, when the parents said the kid was in the balloon and it accidentally took off. And so you've got all these people searching for this balloon and waiting for it to come down, trying to help. And can you think of the mass of people and resources they used to try to rescue that kid? And he was never in there. So how do you de-stress that anger in the public and that anger in those the people from the military, the people from the city who tried to save this kid and realized that they were hoaxed? It's not just like, yeah, we'll get mad at him, we'll put him in jail, we'll do this. There's a lot of debriefing that has to occur with those kind of things as well. And then there's simulation debriefing. That's where we're at. Fanning and Gaba, I think it's Robert Gaba, big writer in the simulation field. They suggest that learning that occurs in briefing is the most important element of their learning, most important element of the simulation. And I after having done this many times, I really agree that that truly is the case. A lot of times the simulation itself is the best. If you do task trainers and you're doing just task training with starting IVs, putting in Foley catheters, those kind of things, in that case, I think the hands-on debriefing is probably maybe a little, hands-on simulation is a little more important than the debriefing. But in the cases that we'll be doing, the learning is going to occur afterwards. You have to provide a safe atmosphere. You have to let these people know, the learners know, it's confidential. Like we mentioned yesterday, what happens here stays here. So you, Dr. So-and-so, you know, I want to let you know, if you screw up, that's fine. This is where we want you to screw up and find those errors, find those areas where you'll make mistakes so you can correct them. You don't want to do that when you're taking care of your patients in real life. And we need to be supportive of that. And that's going to be maybe not too tough, but we have to remember how we respond can show our support of that. We need to have them feel valued and respected. That's another thing that will help to their learning, but also keep them from being stressed or feeling that they were put down for any reason. Focused and honest, focused on the learning objectives that you're having, that you want them to learn. We have to promote clinical reasoning, because medical care, whether it's emergency medical care, non-emergency, or in a walk-in clinic, it's not just based on A equals B, or if A, then B. We have to think beyond that. The clinical reasoning, well, this patient presents with this, 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 and this. My differential diagnosis based on that is these things. But because of the patient history and because of the family history and the meds he's on, that means it's got to be one of these two things. But because of what I hear when I examine the patient or listen to the lungs and the heart, it's pretty much got to be this. So therefore, all I need for the labs are these two things, or maybe none at all. So you work through the process and narrow it down. Use your clinical reasoning skills, what we want to teach to them. Self-evaluation. We give the students, the learners, an opportunity after the event to fill out an evaluation form. Was this beneficial to them? Did the learning objectives get met? Were the instructors adequately prepared to teach me? Do I learn from that instructor's methods? Those kind of things. And then, is this something that I can take back and implement in my own practice? What else did you learn from this event? Those are the kind of self-evaluations that they're going to perform. And then after they go home, or after the simulation afternoon, what happens to the medical students, they'll probably go out to the Blue Moose, and over a few beers, they'll talk about what just happened at that simulation. The hardest part about that is, and that you may have to warn your learners too, one of my patients came in and said, "You teach at the med school, don't you?" I said, "Yeah." "Well, I'm going to let you know, your students are out at Applebee's last Friday night, and they were talking about this patient." I said, "Oh no, you're going to be kidding." "Well, what were they?" I'm just curious because I don't know the first, second, third, or fourth year med students. So what were they talking about? "Well, they were talking about this patient that they had that had AIDS, and it was this woman that lived at the mission." It was this case, you know. They lived at the mission, boy, that can narrow it down. We could go over there and we could find probably a few of them. And they were talking about, they mentioned the name of the patient. They just can't do that. And I said, oh, they weren't talking about a real patient. That was a simulation that we did. That was a fake patient, not a real person even. That kind of thing. But does the public know that? No. But do they know who the people are? Yeah. They identified them as medical students. So guess what? University of North Dakota School of Medicine just got a bad rap. And I had to clear that up. The same thing can happen here. So we still have to maintain some of that confidentiality too. And when we do debriefing, there's a lot of factors that we have to consider. You already know that from just some of the stuff we've talked about. What are your objectives? So when you debrief to the objectives. If it's not in the objective, don't get way off base and start talking about the pathophysiologic basis of thyroid storm. If that's not what you were there for, the patient may have had thyroid storm, but your goal is to get that patient to interact, or the student to interact with the patient and extract information from the patient, and then identify abnormalities on the exam. If that's what it is, don't go into pathophysiology. Once you get your objectives met and there's time and the students really want to and you're prepared for it, go ahead and discuss those things. Those are those teaching moments, those add-on learnings you can do. But get your objectives taken care of before you talk about all the other things. And they'll bring it up. So if they're bringing things up that aren't on the objectives, just say, very good question. Let's talk about that when we're done with the scenario, or when we're done with at the end of the debriefing, we can cover that kind of information. How complex is the scenario? And we talked a little bit about this yesterday. In the patient case that we had today, obviously the patient, we didn't get fully into that when we were talking this morning, but the patient had AIDS. It was a woman who lived at the mission. She had AIDS. She probably had, I can't think of the new name for pneumocystis carinii, pneumonia, but she had that. She probably had lots of other things going on. So we could have really made that case even much more complicated. I could have just said, your objective at the end of this session, the learner will be able to identify 5 things that mark immunosuppressed patient, or something like that. Or we could add symptoms of immunosuppression. We could say, You'll list a differential of 6 things that could account for the findings in this patient. You will discuss the laboratory results. You'll discuss the laboratory results and what they mean in relation to, we could really get deeper and deeper and deeper, but are your learners going to learn what you want from that? Having too many gets way too involved. And I learned that the hard way with first and second year med students. When you try to teach them at a level that's above them, you just lose them. So we have to be careful with that. That's, again, their experience level. The environment, we talked about that this morning as well. Are they familiar with the truck? Do they know what's in there? Do they get into the scenario, then all of a sudden have to start looking for, well, do we have gloves? Do we have masks? Where's the alcohol wipes? Is there IV fluids? You guys experienced that today. You didn't get the appropriate orientation to the environment. It points out how much that's important. And how much time do you have? So you're going to go out to this town and you're going to do simulations. You got 4 hours. You got from 1 o'clock to 5 o'clock. So how many people are you going to have in the 4 hours? How much time do you allot for each person, or how many people in a scenario? So you have to take all those factors into account so you'll know exactly how you're going to do your debriefing. So if you're going to do 15 minutes of debriefing, plan at least double or more of that if you're going to do 15 minutes of simulation time, plan at least double of that for your debriefing time. And sometimes it can be more than double of that. So you have to plan for that because that's where the talking and learning is going to occur. In your curriculum, where do you want simulation? This is not going to apply as much to SIMND right now, but if there were a curriculum to become certified as an emergency room nurse in a critical access hospital, and there is this long curriculum to get your certification, then how does simulation play into that curriculum? What part of it do we have? That'll help you decide, number one, your objectives, but how you're going to debrief it as well. And again, we talked about personalities, relationships. It's going to affect that debriefing also because we have to know how to deal with these people. There's an initial, a second, and a third phase. So initial phase, that's just when you recollect what happened in the scenario. So we get done and just talk to the people. What happened? How did you feel? What were your emotions like? What just happened in this event? And if it was like the case for today, somebody could say, well, we kind of missed the boat on a lady who has some kind of a pulmonary infection. We focused on the wrong thing. Or, this kind of seems like a lady who may be immunocompromised, and they went on. So then let's get further into the debriefing following that. Oops. Then you want to identify any of the emotions or any of the personal things that went on. So I can say to anybody, so jeepers, you seemed like you were really remotely removed from this. I wanted you involved, but I couldn't get you involved. Is there something I'm missing? We talked about some of those things. Get these people in there. And you're going to see emotions. You're going to see fear. You're going to have learners cry on you. Somebody's going to come in there, and it's going to be so absolutely real. Why was that? So you're running a code. It's a code blue, or it's an acute coronary ischemia, and lo and behold, that paramedic's dad just died a week and a half before in the same type of scenario. That's going to be really tough. And I'll tell you, you're going to come across that because some of these scenarios are popular scenarios that you see out in the field quite often. So one of these times, you're going to strike a nerve with somebody, not because they hate you, they don't like what's going on, but aha, it just brought back deja vu for them. So then we want to find out how they view the rest of the group, and how do their views get accepted by the other groups? Do they see the simulation the same way the others in the group see it? So all those views and how they work, we want to try to bring all those things out. Can you do all of this in one debriefing? Probably not. And do you need to do it in every briefing? Probably not. But these are the things that we look for. when we try to get through the debriefing. And so when you're doing the debriefing, you want to always be aware of all of these things. And having an awareness of this, you'll be able to bring it up when you see them. So we start with a pre-brief. We talked about that a little bit this morning. You know, if I would have seen the room beforehand and known where things were, I didn't know, you know, maybe we could have been told how to check the pulses and things. The pre-briefing, we talked about that quite a bit this morning. So that's going to be an important thing about pre-briefing. Ground rules too. You know, we talked about all this before, but set the ground rules. And if, like Dr. Kilgore says, he's very blunt and to the point, and if that's the way you're going to be, please let them know that and explain that it's not related to a poor job, but that's the way I teach. And if it's offensive to you, please point it out to me and I'll change. But set some ground rules when you do this. And you want to orient. Cheryl was talking about this, I think, yesterday. 10% of the people that you do in orientation, no matter what you do, they're going to learn. They're just going to learn with anything. 10%, no matter what you do, just aren't going to learn. This isn't going to work for them. Then there's going to be that 80% that really work hard, that really get engaged, and they're going to really take home a whole lot from this. They have to work at it. But this is something, they'll be interactive. This will be something very real for them. And when you orient, you have to orient them to the simulator. Once you've been out to the site and they know your simulators, they know the Mediman, they know the PediaSim, they know all of these things pretty well because you've used it with them before, it's going to be much easier. And your pre-briefing and your introduction is going to be less. And you want to give them the time frame and you want to give them the roles. We talked a little bit about that this morning too. But it's very important to give them that time frame. You have 12 minutes to take a focused history and do a focused physical exam on this patient. We won't go past that, but you have 12 minutes. So when you see them in the scenario at 8 minutes and they're still trying to get a history and they haven't laid a hand on the patient yet, you may have to decide in advance, well, if they're going way too long, you may have to push them forward. I think it's time now that, you know, it's 4 minutes into the scenario, you've got a lot to do in terms of the exam, let's move on to the exam. And then so you move them to the exam, and during the debriefing at the bedside, you talk a little bit about how they can speed it up so that when they redo it again, they can get that sense that, aha, now we got it, we can accomplish a little bit more. So during the simulation, you actually do something. This was one, was this the Hillsborough one? Yep. Where we had a patient riding a motorcycle, and the motorcycle slid out of control, and you know how the telephone poles have some of them have those cables, the guy wires going around? Well, went right through one of the guy wires, and guess what came off? The guy lost part of his leg. So here's a simulator, and the motorcycle's laying upside down close to him. So the paramedics and nurses are out there taking care of them. This is where they're getting their hands dirty. They're doing the actual thing that they would do right out in the field. So they're exploring the ground. They're discovering what they can and can't do, and they're taking care of a patient. Then what we did is a rapid debrief. We did it right there, right out on the berm of that, on the grass, and we just talked to them about those things. What just happened? What were your emotions here? What can you change? How can you get better? What went right? What went wrong? Talking through a lot of things that they experienced, and we tried to gear it right down to their level of learning. At that rapid debrief, we asked them to give us a general review. So tell us what you have here. And that's where they go, we have a 27-year-old male who was riding a motorcycle at high rate of speed, hit this guy wire, severed his leg. We were called to the scene. We got there in 8 minutes after the accident happened, and then quickly giving their vitals and everything else, all the pertinent information. So what potentially is the problem here? You have this lady who comes in that's a homeless person, stays at the shelter, she's got a cough, she drinks, she smokes, all her belongings are right there in that bag. da da da. So what are the possibilities? Pneumonia is going to be one of them. What type of pneumonia? Bacterial, fungal, viral, tuberculosis, any of those kind of things. What else could you have? Asthma attack, congestive heart failure. Then you start working at why are they on the differential and why should you take them off the differential. And again, this is, you have to do it at the level of the learner. And again, if this is first responders, you're not going to be talking about differential diagnoses. If they're doctors, you're going to hit them hard with that. If it's paramedics and nurses who are decision makers, they end up in that range as well, that you use that. So if they're in the area where they'll do treatments, you kind of discuss what the immediate needs are and what kind of protocols they follow. One of the tricks, one of the habits that students fall into, they want to do the complete care. So they think, in this scenario, I've got that 12 minutes to take care, diagnose, treat, get the exact drugs, get the surgeons here, get them in ICU, heal them, and get them home. So they're trying to do all they can. You got to focus. Wait a minute. You're just in the emergency room. Your job is done when you stabilize the patient and get the bed up in ICU ready and an accepting physician to take them. You don't have to push past that. So we have to remind them what the immediate needs are. And the plan of care, what are the next steps? When you get to the point where you're going to transfer to ICU, or you get to the point that you're going to call the cardiologist and send them to the cath lab, that's the end of the scenario. That's where the next steps will lead us. Then you do the simulation again, but guess what? It always goes better this time. Now the students seem fully engaged. They're even more engaged, and it's fun for you to watch because you can see how much better the students did. When they get done in the rapid or the big debrief at the end, they're going to tell you, God, I still felt like I was lost. I didn't know anything. And you're going to stand back and say, I really saw care that you guys could take care of me. I saw that kind of care there. And they're going, what? I didn't feel that way. So then you start walking them through it and they'll understand how much better. This is where we allow for their successes. And at that second time around in the simulation, if they're still having a little trouble, I'll guide them a little bit. And they go, oh yeah. And then they'll just keep on going. It's kind of like when in our church, when our pastor has the confirmands, the kids going through confirmation, they have to recite verses in front of the church. And they get up there and they have trouble. For God so loved the world that he, and then the pastor will just give an extra word and they can just keep on going. The same thing happens when you're doing this. They're stuck. They, oh my gosh, what am I going to do next? And all you have to do is maybe just say, here's the neck brace, or maybe, here's the kit with the IV in it. Oh yes. And then they'll keep on going. And because of the learning on the first time, they'll do really, really well. Principles. You want to foster discussion in a non-threatening fashion. The one thing that you want to avoid, and I think it'll come out later, is you don't want to do all the talking. You're not a lecturer in the debriefing because you want them to generate all the learning, generate their talking. Leverage that aha moment. So when somebody says, that first time I was lost, but that second time, after the team leader mentioned, why don't we consider this? And I went back and listened. I thought, oh yeah, now I get it. So then you focus on that and say, so I understand that you really got this. That was new to you. What do you think it was that made it stand out? And they'll say, well, really what made it stand out is we have a good team member who pointed out to me that this is going to work, that this was great. I would have never thought of it. What can you take home? How can you teach your colleagues back at home about that? Well, I think I'm going to be a better team member. I'm not going to be afraid to tell somebody. You can keep on going. You can foster that discussion with them. All of you have real-world experiences. This is where you can say, in my experience, I had a patient once where we did this. This is what happened, and it really turned out well. How could you apply something like that to the simulation we just did? And then they may get those aha moments, or they'll see the connection by you giving a real-world experience. And then you can help them apply it to real-world practice. Have you ever taken care of this kind of a case? And they'll say, well, no, I never really have. Is there anything like that that you have taken care of? Well, you know, I did take care of a patient who had this, and I know it's not pneumonia, but you know, a lot of the findings were the same. And you know, I might be able to use some of those principles in that, so you can help broaden their experience with it. Questions, opening lines. You know, we want to use open-ended questions. We want to get the debriefing going. And when you first are in charge of the debriefing, and you've got 4 learners there, and it's you and 2 other of your crew, and you're the debriefing chair today. You're going to lead the debriefing. So we sit down and look at it, and your first question after all the debriefing, what do you say? If you haven't done this before, well, how'd it go? You know, you don't, not too bad, but what were your first impressions when you arrived at the scene? What we asked those people with that motorcycle accident, what were your first impressions? And you get everything from scared to death to, man, I knew right what to do. That trauma just turns me on. It really got me going. I knew what to do. Or I was scared because I thought we were going to lose that patient. I've never seen so much blood in my life. You know, those kind of impressions come out. And you want to let them have a chance to talk about that. And if you see emotion with it, you want to play up on that a little bit and see where they're at with it. If you're doing a handover, for example, your simulation is going to be with the EMS dropping the patient off at the hospital. So you're using the back end of the truck where the ambulance is. So you're sitting there, and you're now going to take the patient and roll the patient into the emergency room. So you take them out of the back end of the ambulance, go around to the front end of the SIMND truck, go around to the front end of the SIMND truck, and you're bringing the patient then into the emergency room.
So are we to have that ability to kind of like enjoy them?
Sure, you can take them out of the back of the truck and into their own ER, but a lot of times their own ER is busy, and you know they have costs to restock everything. So if you have to do it, take them out of the back, wheel along to the side, bring them in the front, or we may be able to bring them straight through the control room. You know, there's some logistical things there. But so you bring them in. So how was that handoff? Did you get an adequate handover? You know, did the paramedics give you a report that gave you enough information to work on? How did you feel when they gave you the report? So you can start talking. It's a good way to start. What other sources of information from the patient or the scenario could you have obtained? That motorcycle accident that we did, you know, doing a site survey was really important. You know, they found the leg separated from the patient. It was, I mean, right there, of course, but what else is on the scene that they needed to pay a little bit of attention to? The motorcycle, it was upside down. Is there gas leaking from the motorcycle? Is anybody and the bystanders around smoking and there's gas around? You know, those kind of things they have to pay attention to. If it looked really hectic to you, you can start out the scenario. Ryan, who was the leader? And you can say, well, I was the leader. What was your first thought when you took control of that? And then see where they're at. Not telling them, you did a rotten job controlling it, but what was your first thought? What's your best impression of how you should have controlled that? You know, just open it up somehow. Did anybody ask for help? You know, they're talking right away and say, wow, it was confusing, whatever. And they're all talking and you're ready to get it organized, and you hear them talking about things and how, oh man, that was just a nightmare. And then when you say, well, let's get the debriefing started. Did anybody ask for help? And it gets real quiet, and just wait and say, you know, I think we probably should have. Little questions like that can get them stimulated. And how do you feel that went? The biggest thing that is tough for me is when we videotape the students and one of the students fails, like the exam that's going on right now. I talked to Joe, fortunately, no failures so far. But when one of the students fails, I get him in my office and I say, first of all, you didn't get by the exam, you didn't have a passing grade, you need to look at your video, take some notes, here's the checklist. When you're done with that, I want you to come and talk with me. So they come and talk with me. And when I say, well, how do you think it went when you watched your video? Oh, I thought I did pretty doggone good. Okay, that's a challenge because we've got a lot of work to do, because obviously one of my graders or myself thought that they did a very poor job. And so we've got to find out, well, why did you think you did well when we just told you failed? You know, I don't say it that way, but that's what we're going to look at. So we want to find out if they thought it went well or what went well. This is what I drew on the board when we were talking with Dr. Kilgore. But the emotional state can affect how much you learn, how much you may forget. And low stress, lots of things can happen. Extreme stress, we're pushing them past the point. Learning is not very good. Under low stress, again, learning is not real good at that point. Not the kind of learning that we want to teach. So we want to get them past the middle and just to the right side of the yellow. That's where they have an experience where they're going to learn a lot more, because there is stress, there's demands put on them, they're pushed a little bit, and they can learn a little bit more. So what's going to make the difference about that? Have they had prior life experiences that allow them to be at this level, or have they never been pushed past that middle level? And sometimes you find people who've never had much more than just low stress. Those are going to be tough learners to get on your side. So some practical aspects. Where are you going to debrief them? You've got this truck sitting out in their parking lot. Their emergency room is busy. Where are you going to debrief them? It's a nice hot summer day. You've got a canopy on the outside and some tables. Do you want to do it out there? You might be able to. What about all the people going in and out of the hospital emergency room door? A lot of distractions. Why can't you just do it in the front end here? The bump outs are there. The simulator is sitting there. Why can't we debrief in that front end? You sure can. We have access to debriefing video if we need it at that point. We sure could do it. What's going to prevent you from, in the ambulance in the back, there's two sides that you can sit on, and if you've got 4 people, 2 on each side, and you can stand as 1 or 2 of the debriefers, and you can debrief them right there. And you have the computer that you can just turn from the control room, so you can debrief them right in there. Or maybe the perfect setting is the emergency room. When you get done, there's going to be another crew that's coming in. So it may take, we were talking yesterday, can 2 people run simulation if you only have 2? Possibly. So maybe what you've done is you've trained somebody, or you're going to utilize somebody from their staff to help you debrief. So 2 of you stay out and run scenarios, and you and somebody from their institution are in the conference room of the ER, and you're doing the debriefings as they come rolling through. This is something that you figure out what works best for you and for that scenario. Just make sure it's comfortable, it's private. If you have seating, that's great. We have seating in ours. That does promote a lot. People tend to be a little bit more focused if they're sitting down rather than just standing there. So that can be helpful. The in situ simulations, if we do a simulation in the emergency room or in an ICU or right in a real care setting, but removed from real patients, we may have to do the debriefing right there at the bedside. Those things happen as well. We want to set the expectations, what the debriefing is going to be like. You can say, now in the debriefing, you're doing your pre-brief, you showed them the simulator, how things work, how we're going to run it. Now during the debriefing at the end, we're going to talk about your emotions. I'm going to find out how you felt with this. We're going to point out all those things that you did well. We're going to talk about the things that didn't go so well and what you could do better. We're going to talk about what you learned on these things. So they know what to expect when they get to the debriefing period. And again, please tell them about the confidentiality and the fact that what happens here stays here, that you're never going to condemn anybody. This is all artificial, but close as we can get to real, so they can have some learning with it. Include all the participants. You're going to find some people that aren't involved at all. But if you're doing a small group, and it's usually going to be fairly small groups, get all of them involved. If one person is just dominating the talking, you're going to have to find a way to shift it to get it to somebody else who doesn't get a lot of talking. they're continuing to talk, continuing to talk. When they take a breath, you can say, thanks, I really appreciate all that you're inputting in there. Let's see what George thinks. Let's move over to George and see what he thinks. And then George doesn't want to talk much. And so you say, I know you have feelings. I know you learned something. I could tell by the way you responded there that you were thinking something when this happened. It looked like you wanted to jump in, but you didn't. Why did you hesitate? You know, so you can get these people in there somehow. This is one that's kind of tough. Reflect the questions back. I think of when a student asked me, so Dr. Allen, what is that little mark on the ECG right there? I'm not going to go, so what is that little mark on the ECG? Yeah. He asked me a point-blank question. I'm going to tell him that's the P wave. But sometimes you can reflect it back. And that you have to be pretty good at. And I don't know that I'm real good at reflecting back questions. But if you're used to that technique, please go ahead and do that. Silence. 10 seconds seems like about 10 minutes to me. And that's one of those things where our medical students don't want to talk a lot because, number one, they want to get out of there so they can go study. Number two, they really aren't going to look dumb in front of their classmates. That is, I think, verboten in their realm. They just won't do it. So Dr. Levitt and I just decided, well, we'll just hold off. So we ask a question, and nobody answers. And I'll ask one, and so Dr. Levitt says, I think Dr. Allen just asked a question. And everybody's kind of smiling, and so I'll just kind of stand here. And I've got 70 students looking at me, and just kind of stand there. So I'll say, well, I'll pull up a chair, and I'll say, I'll wait, because it's more fun for me if, this is what I tell the students, it's more fun for me if I'm involved with you, but if we're not involved, it doesn't get fun. Pretty soon they start talking, and then sometimes you can't shut them up. But you got to be careful about how you do that one. Body language, again, we talked a little bit about that. You'll want to focus in on body language that you notice that may be disruptive or that may inhibit their learning or something. You will see that. So kind of focus in on that. I don't have an exact way to tell you how to get them involved other than maybe reflect back the body language and say, it looks like you've got a little bit of anger there, or it looks like you're hiding something, or it looks like you've got something to let us know, or I'll bet you have some pretty good learning with your background. What can you tell us about it? Try to open them up. And group dynamics. Somebody asked this morning about how do we know what kind of labs they have? How do we know what they have available, what the makeup of the groups are? Once you get the assignment to go out and you might want to call in advance, you might want to call their supervisor. So the head nurse in ICU is called, wants you to come out and do some education for the emergency room nurses and paramedics. So you can talk to the nurse and say, is there anything that would help me to prepare for this teaching that when we come out here later this week? Is there any difficult situations or any things that you need to learn? Is there anything about the group that makes it hard to work together? So you can work with them on that. And the head nurse will probably tell you, the chief paramedic will probably tell you, hey, we got a few people who they can't break the mold and they can't get involved. They're just not team players yet. And so knowing some of that stuff in advance you can non-threateningly bring that out for them. Open-ended, non-judgmental, why, what, how, where, that kind of stuff we talked about. Follow up on their comments. One thing that they've seen in the past is one of the participants will make a comment. Like, I really felt lost when we went in this scenario. And somebody else say, well, I didn't feel so lost because I remember we did this on last week, something like this, and that person will go on and on and on and on and just overshadow that one that said, I really felt lost. And that comment will get lost. You have to remember to get back to those people. We talked about the rest of that. Don't take a lot of things for granted. A lot of this other stuff we've covered in one sense or another. Frames. A lot of the patients, a lot of the learners are going to have frames from their previous learning. And again, we talked a little bit about yesterday, but they'll have a frame coming into this simulation. This is the way I view code blues. And this is the way I, as a doctor, expect everybody else to work with me. So I'm going into this simulation with this frame. I expect them to respond like this. It may or may not happen. So then they get to the other side. They got these ideas, they get the frame, and there's the results. And the results might be that I couldn't get that nurse to do what I wanted to do. That paramedic was pretty good helping me, or vice versa. But every time I go through this, I get some people who just, they're not getting it. They're just not doing what I want them to do. So then what they're going to do, they get through the debriefing. They understand why those people aren't going to do what they want to do. And if we're appropriate in it and they are open to learning, they'll change that. They'll change their actions and they'll see a better result. Sometimes they'll go back and change their frame. Their frame was, when I'm in that simulation, I'm the boss and whatever I say has to be done. And that's their frame. They'll go back and say, I'm the team leader. I've got all these people to help. They're my team. And I'm going to seek their input to help change my decisions. So you've changed their frame so they can go through the whole thing. And that's the goal a lot of times, is to change their frame or maybe just change their actions. So you can see how this little diagram may play out in your debriefing characteristics. There's a few helpful questions we put here. And a lot of that we've already covered. It's on the PowerPoint that you'll take with you as well. This idea about calling on someone other than the primary participant, so the team leader. So one of the things I like to do is ask the active observer. So you were standing back watching the whole thing. What's your overall impression of what you just saw happen there? And then they can start going on. And very often, the other team members will start piping in, and you may not have to say anything for quite a while. They're carrying on the debriefing pretty well. So these are different things that you can bring out and ask them. So these are just all statements. You know, I can just review these things. You can read them and you have them in your packet. These are just all helpful statements that you might be able to use in different debriefing situations. Fixation errors, people are stuck on something. They cannot get over this one error, no matter how much you debrief them, how much others are bringing it up. They may be stuck on something and they keep making the errors. They're not seeing what they're doing. So then you start getting on to what are they thinking at the time? What do they think happened? So you have to get through those questions that way too. What made it difficult for others? Has that happened in your real life? Because if they've got these errors that they're repeating over and over and over, they've established a pattern. And you will see that too. I haven't seen it in a long time, but I've seen medical residents who were never taught the right way to do something, or nobody ever observed them checking for a thyroid or how to palpate a thyroid. So I have a resident with me and watching him do an exam, and he says, I can't feel the thyroid. And I said, man, this guy's got a massive goiter. Well, he doesn't. I can't feel a thyroid. So show me how you examine a thyroid. And then you find out he's way off on the thyroid. He's examining for the thyroid way over here. He read it in a book once when he was a first-year med student and practiced it. Nobody ever watched him do it. Somehow he failed it on the exam, and unfortunately, the grader didn't go back and say somebody needs to reteach him how. So he gets through thinking he's doing it right his whole career and has done it wrong every single time. So we have to see about correcting those kind of things when they happen. Too much talking. I already talked about that. Personal evaluation before concluding. So when you get all done, everybody's done their talking and it's gone very well, and then you put your personal evaluation. Well, let me just tell you what I thought happened here. You guys are all right, it went really well, but I really think that you know, you guys are going to have to get better at this, and you know, your own personal evaluation about what John Allen thought happened there shouldn't be in there. It should be from the debriefing standpoint, here's what we saw, and no discredits or anything like that. Too much technical stuff, being too judgmental, interrupting them often is not good. We know that. Doctors are very good at interrupting in the first 9 seconds, I think. And then that game of guess what I'm thinking. Don't put them on the spot to guess what you're thinking it should be. It's not about what you're thinking. It's all about what they're learning. And you have to have an agenda. Base that on your objectives. Use cognitive aids. Give them triggers. If they're kind of stuck on something, you're asking a question, give them a little trigger comment that tells them where you want to go. For example, how did everybody feel during that stressful situation? Nobody's talking. And give them a little trigger. Say, you know, I felt a little bit nervous when I first did that one. How about you guys? And then somebody will come out, yeah, I really did too. But just making it okay by saying you felt that way when you went through it, or you felt that way even during that scenario. Good debriefing, we've talked about those kind of things. So here's some references to debriefing. There's, I think, 3 or 2.5 pages of references on the back of this. There are more references than this in debriefing. That's probably one of the biggest things in the simulation literature is references on debriefing. Does anybody have a subscription to the Journal of Simulation in Healthcare? If you're not members of SSIH or SSH, Society for Simulation in Healthcare, I'd strongly encourage you to become a member, and then their journal comes to you. You can get on listservs, any kind of listservs that you want. You have access to all kinds of resources by becoming a member. They have an annual, the annual International Simulation Conference called IMSH is in a nice place in America every year, and you have to be a member to go. It's an expensive conference, but it's fantastic.
Is it somewhere warm?
Yes. Yes, it's New Orleans, it's San Francisco, it's San Diego, Florida. Yeah, it's pretty good, yeah. Maybe we'll get one in Fargo one of these days.